Welcome to another episode of Dysphagia Matters. My name is Jule and with me is Julia.
Hello, everyone.
In this episode, we're joined by Professor Kathryn Steadman, who gave a great presentation at last year's ESSD conference in Münster, in Germany. Her talk explored the question, does swallowing tablets with an ITSI level 4 gel impact drug absorption?
And because this topic isn't discussed much and Kathryn brings a lot of expertise as a pharmacist, we're happy to have her with us to talk about safe and effective medication intake for people with dysphagia.
So together we discuss the role of swallowing gels in medication administration, dysphagia as a potential side effect of medication, the pros and cons of crushing tablets or pills, and what the future might hold for medication strategies in dysphagia care.
Have fun listening. Yeah, hello, Kathryn, and welcome to the Dysphagia Matters podcast. We're really happy to have you with us today.
Thanks. I'm really happy to be here.
So you are a pharmacist working at the University of Queensland in Australia. How did you get to work on the topic of dysphagia?
Yes, I was a pharmacist originally. I qualified in the UK, and then I worked for Boots the Chemist in London for a while I was doing my PhD. And then after a variety of different things, I ended up in Australia working at the University of Queensland. I joined here about 15 years ago. And at that point, I met Julie Shakiro, who is speech pathologist extraordinaire. And she was teaching into our fourth year, teaching them about dysphagia and the difficulties of swallowing. So Julie had students use marshmallows and try and swallow them without using their tongue to try and show them how difficult it is to swallow. And she had everybody really well engaged. So I started talking to Julie and we discussed about how we could look at improving options for people to swallow their medicines. And at that point, there wasn't anything in the market at all. So, it was really an open field of desperation to help people with their medicines.
What a great example or trial to feel it by yourself. Can you explain why swallowing medications can be a challenge for people with dysphagia?
Yeah, well, tablets at the best of times for people who can swallow, perfect swallowing function, they're really hard, dry bricks and they're difficult. About 10 to 15% of the population actually find it difficult to swallow medicines. And they're mostly people who can have no other problem with swallowing. They would normally gag and spit it out. Or if it gets stuck on the way down in the esophagus, then they can at least drink plenty of water and flush it through. But once you then add in any level of swallowing dysfunction, no matter what type it is, these little hard, dry bricks are actually quite dangerous because they can get stuck in your airway, they can get stuck in your esophagus. And so it's, there's physical blockage, there's a blistering of the mucous membranes if they get stuck. And so obviously they're quite dangerous.
And how do pharmacists who work in a clinic, for example, typically address the needs of the people with dysphagia or who need to take maybe multiple medications daily?
The first thing is that the pharmacist has to know that there's an issue with swallowing medicines, and actually often the information about the dysphagia is separate to the information about the medicines. And so it's very system focused, different depending on where you work. And so if the pharmacist is aware, we know that pharmacists don't necessarily ask, so there's an issue there. But if they're aware, then pharmacists will tend to look at what can be done about the medicines to make it easier to swallow. So they'll tend to want to do, you could do a full medicines review and you can look at whether there's a change to the medicines to make a different formulation or change it so that you don't have to take as many doses in a day. That kind of approach would probably be the approach a pharmacist would take.
Yeah, that's a really good point. I think communication is key as always, but it can be quite hard.
So you have studied swallowing gels in your research. Can you tell us more about them? And first, what are they made of?
Yeah, so swallowing gels are mostly, the main thing that's doing the thickening tends to be plant gums, like the swallowing gels that I've worked with. It's carrageenan, It's the same sort of thickener behavior as the xanthan gum or the agar or the guar gum that you get in thickeners that thicken fluids. So it's essentially the same thing. And then they add other components that give it a little bit of lubricant. So it makes it easier to slide. So it's not just about thickening, it's that sort of lubrication so that it will slide down the esophagus easily.
How do they work and when are they recommended?
We started out originally looking at products that people with dysphagia are commonly using to swallow their medicines. And so back in around 2010, that was mainly products that you use for hydration, so thickened liquids, or it was thickened food products like yogurt, custard, jam, and applesauce. So we were looking at those and looking at their properties. But then in 2015, in Australia at least, the first swallowing gels became available. And so we focused on working with Gloop because that's the product that's available here. And it was great, really. We'd gone from a position of thinking we needed to create this product ourselves and get something in the market to going, oh, hang on a minute, this looks like it's got all the qualities of what we were imagining. And so we set about looking at, well, are the properties right? Are they correct? Are they suitable? Are they safe in dysphagia? And now originally it was designed as a gel to hide tablets and capsules as whole medicines for people who don't necessarily have dysphagia. They just can't swallow their pills. With that design in mind, we started looking at whole tablets originally and then realized that they were actually being used with people with dysphagia and crushed tablets. So then we needed to look at that sort of area as well. And so in terms of what they are gels that they're designed to hide the tablet. And so that they hide it from the oral sensory receptors so that you avoid the gag reflex, basically. And the idea is that it reduces the number of people who are needlessly splitting or crushing their tablets. And the ideal swallowing gel would be something that envelops the medicine. It holds its form when it's on your tongue. It doesn't sort of fall apart in your mouth, holds its form. And then when you swallow, it goes nicely, slides beautifully down the esophagus, doesn't get stuck anywhere. It helps the tablet get all the way down. And then when it gets into the stomach, it should leave the tablet. And so that the tablet can then carry on and do its own thing. And everything that we did with it, everything that we tried with it has shown that actually, yes, it's a great product and it does do pretty much exactly what we would want it to do. And so we've worked mostly with IDSI level 3 and level 4 Gloop products.
Sounds quite fancy to have it all wrapped up and it works so beautifully that it sticks to the tablet all the way to the stomach and then just there it resolves.
Yes, and there's lots of different types of swallowing gels. Some do that well and some not so much. So
okay.
And they're similar to using food, but they're designed in a way to try and do that actively rather than just as an accident.
Yeah, great. So are all of them safe and effective or just some of them? And are they safe and effective for all types of medications or are there specific limitations?
Okay, let's talk about whole tablets and capsules first because they're quite different to when you crush a tablet and use the gel. So we'll talk first about whole tablets. And I've worked mostly with Gloop as that's been the only option in Australia up until now. And we've worked mostly with a standard tablet, like something like paracetamol as a model tablet. And it's a big, round, horrible, dry tablet.
It is.
A lot of people complain about, get stuck. You're trying to swallow 500 milligrams at a time. It's a big thing. So when you look at whole tablets and delivering those with an IDSI level 3 or level 4, and I'm talking about Gloop here, then what we found with a whole tablet is that drug absorption is basically the same, but just slightly delayed. And that's basically because Gloop is doing its job really well. It's enveloping the medicine. As you swallow, it's helping it slide down the esophagus. And once it's there, it's in a larger volume of liquid and the Gloop disperses and the water can then access the tablet and it can then the tablet does, carries on with its usual life at that point. And so if it's immediate release, it disintegrates and the drug dissolves. And if it's designed to have some other delayed release profile, then it carries on with that. It'll hang around as long as it's going to hang around. And so that slight delay of around 15 minutes is just that delay in the immediate release tablet sort of accessing the water in the stomach. And but otherwise the absorption is pretty much the same. And so is it valid for all tablets and capsules? I can't say for sure. But I personally, having worked with this stuff and seen the results and worked with it in vitro, so in the lab and in people, I think it's probably fine with pretty much anything. I can't see any reason not to use it anyway. And certainly it's now had more research than any food product has had in this area. So like I'm comfortable with using these swallowing gels. Is it the same for all swallowing gels? I would say probably they're going to be quite similar. But I have noticed, in Europe, you've got some different types than we have here. And it's more about the physical form, really, is that they don't necessarily hold their form on your tongue and envelop the tablet and keep it enveloped as you swallow. And so there's potentially some variation with that. And I think that you speech pathologists are the best ones to see that. You try it out yourself without a tablet and you'll know if it's going to hold its form well enough. You can see it on a spoon, whether it's going to envelop the tablet well and give it that sort of lubrication as you swallow. I think a lot of it you can do visually yourselves to know whether it's going to work.
Yeah, or check on video fluoroscopy if you have the option.
Yes, yeah, absolutely.
Great, thank you.
And in case the patient is also not able to swallow HC3 or 4 levels instead of the swallowing gels, because then they would also not be suitable for that patient, are there any alternative formulations that we could use to help administer the medication?
Yeah. I mean, in pharmacy, there's a whole range of different dose forms. You can look at things like liquids or tablets that dissolve in the mouth. Medicated films are also another option, or changing the route of administration completely away from oral so that you can do transdermal across the skin, or intranasal, or even rectal, or potentially even injectable. But, in terms of it being commercially available, then there's a lot more restriction. And so while pharmacies can actually make lots of different options, we call it compounding. So as long as it's, if it's prescribed, you can ask for all sorts of different types of dose forms, but it can become quite expensive, especially if it's for multiple medications. So that doesn't tend to get that much use. And I think a lot of doctors don't really even think about it for patients either, this individualizing medicines for them as a formulation. So there's options, but there's just not a great deal of products available commercially in many different dose forms, unfortunately. And so we come back then to ultimately having to crush tablets of people that can't swallow them.
Yeah, exactly. I guess that's one of the most common approaches, to crush or to break the pills to make them smaller and easier to swallow. Are there any risks associated with that?
All right, there's actually 3 topics to talk about here, because there's 3 ways in which there's a potential risk. We've got the tablet itself, the actual crushing process, and then what it's mixed with. So I'm gonna talk about those 3 things. Okay. So firstly, the tablets itself. Actually, realistically, most tablets that are out there are actually okay to crush. Let's be honest. They're designed to be immediate release. And when you crush an immediate release tablet, you are making it faster. You are giving a higher concentration of drug at that point in time that's faster. So you do have to bear that in mind. It's not ideal, but it's probably not too bad. But there are some medicines that it's not okay to crush, and that those ones can be really worrying. And the main example of those are medicines with a large amount of drug in them that are designed to be released slowly across a long period of time. And so, if you imagine, instead of having 4 times a day dose, it's designed to have all of that 4 times a day dose all in one tablet, but not released, gradually. It's released gradually. If instead you crush it, and that 4 times a day dose is all released in one go, and so suddenly you've got this massive concentration released in your body, that can be quite toxic. And then if you're doing that repeatedly, day after day, you instead of having this nice even release of drug, you've got this very, very sudden high level of drug and then nothing, and then high level of drug and then nothing, and that can be really quite disastrous for people's health. So there is a real worry from pharmacists about people crushing tablets. And so it's really important to check for each tablet type that needs to be crushed, is it actually safe? And there are references that can tell you that. All right, so now secondly, the crushing process. in our work, actually, this is really the place that can be definitely improved, because all the time, even if you do the best possible crush, you're never going to get more than 90, maybe 95% of the drug, but probably more like 90% of the medicine being swallowed, because you're going to lose a bit in the process of crushing and transferring, no matter what the device. Some devices are better than others. If you can do the crush inside a bag, but even when you try and tip out your powder from the bag, you've got powder being stuck on the inside. Whatever happens, you don't get the full dose. And then add to that busy nurses, people not really understanding the concept of what's actually in their tablet. And suddenly you're not getting anywhere near 90% of the medicine being ingested and absorbed. So the crushing process is really important. And I think that's one of the main areas that really needs a bit more work. All right. And thirdly, we need our crushed powder to be mixed with something. Now, a good thing about the swallowing gels with crushed tablets is that when you're looking at an immediate release tablet, we find that when you mix it with the swallowing gel, it actually calms down that big initial absorption a bit. So it's not quite as full on with the sudden drug release. So using the swallowing gel, we've done work with the IDSI level 4 gloop. That one definitely improves that sudden hit of drug. So what's happening is the gel is surrounding the powder, the particles of powder, and slowing the water from having access to it. And so it just sort of brings back that drug absorption more to what you would see for the whole tablet. Or at least that's what we saw when we used paracetamol in gloop. And I'd say the same goes for powders that are designed to be mixed with water. And so if you need to give somebody a powder, they can actually be mixed in with a swallowing gel instead. And we tried all sorts of sachets, but you can fit all of that into about 2 pumps of swallowing gel without any issue. And it doesn't affect the IDSI classification of the gel, which is the important thing for swallowing safety. Now, use of food is really common. And while it's been done forever, and clearly, it's relatively safe in terms of the swallowing safety, there's the inherent variability between foods. And every time you switch method, then you're going to get a slightly different effect on the absorption. And every time you switch a method, then you're going to get a different amount of crushed tablet that actually makes it into the patient. I think ideally there is one method that's used, it's set up in hospital, and then that same method is used by the patient when they go home. So you get this consistency and approach to taking the medicines. And that way, you don't get so much fluctuation in the levels of medicines that are being absorbed.
And sorry, what about yogurt or dairy? I think that's the biggest question oftentimes for SLTs. I think some have heard that there are some risks and the tablets or the medication might not work the way it's supposed to be, at least with some. Are there any risks, or could we use, if, like you said, if we set up just one food in the clinic and then make the patient take this at home as well? Is it okay all the way through, or should we prefer, for example, applesauce instead of yogurt?
Yeah, it's an interesting one, that yogurt dairy product conundrum. Generally, that's an issue with only certain medicines. There's not that many. And so, there's certain medicines that we just know, it'll say on the box, don't take with dairy products. In fact, the amount of dairy product that you're using in delivering a medicine is not the same as a whole meal of dairy product. If you're going to talk about giving somebody a glass of milk to swallow to send a medicine down, well, no. Just a teaspoon or a spoon of yogurt at that point, and doing it regularly, the same thing every single time, that actually is probably not so much of a problem, even with those medicines that it's then going to, what it does is it's the ones where it chelates the medicine and it sort of prevents the medicine from being able to dissolve and be able to be absorbed. So ideally, if somebody is on those kind of medicines, the tetracyclines or whatever else, you just don't use that. But actually, for most things, it's probably fine. If there's a yogurt that's the right thickness, it's going to be reproducible. Yeah, that's probably going to be fine. The main thing really is using the same thing and not swapping around and using juice one day and a thickened fluid thickened with xanthan gum another day, and then a swallowing gel another day, and then a piece of banana bread a different day. It's that kind of swapping around that's I'm more concerned about.
I feel like particularly levodopa for people with Parkinson's, that this is something that came up quite a lot. So you would say that just if you take it with a teaspoonful of yogurt, the levodopa, that doesn't interfere?
Yeah, it's more about it being reproducible. I wouldn't want
Okay.
to say, oh no, it's going to be fine because I haven't tested it. It's more about avoiding an entire meal that's, you're going to fill your stomach up with something that's going to stop it from being absorbed. That's what you're trying to avoid. I think it's more about if you're consistently doing the same thing, it's probably less of an issue. It's difficult. Some things are very, very, very dependent on having a completely empty stomach. And so that's difficult because then whatever you give with it, you're putting something into the stomach. So if you're trying to swallow an alendronic acid tablet, which really needs an empty stomach, how on earth do you do that? You've got to, you've got to put it in there with something. But again, it's about the fact that when you're delivering it with something like a swallowing gel or a food item, that it's only a small quantity of food item. It's not a big meal. It's not the same thing as eating a meal that then fills the whole stomach and changes the pH of the stomach and then changes the emptying time of the stomach. It's a different thing just to put 1 teaspoon of food in. But I have to qualify all of this, that this is coming from a place of common sense. And we really should measure this stuff, really. We really, it's the sort of thing that would make great research if somebody wants to do it.
So when is it appropriate to consider liquid formulations, and are there maybe any downsides to using liquid alternatives?
Well, we've measured the IDSI thickness of pretty much every commercial liquid that's available in Australia. So that's 121 of them. And the liquids are all IDSI level 0 to 2, mostly in that IDSI level 0 and 1 range. So if you've got somebody with dysphagia who can manage that thickness, that's okay, but it might be a bit thin. And so really watch out with that. For thickening it, we did manage to get at least 2.5 mils of almost all of those liquids into 2 pumps of the swallowing gel. That was using Gloop Fort, so the IDSI level 4, and it didn't thin to level 3. So you can actually deliver, a spoonful, if it's 5 mils, with a few pumps of Gloop Fort, and you can still manage to keep that thickness. So I think that's important to think about as an option. And there was only a couple out of that, over 100 that it didn't work for, and it would be really obvious. So if you used it and you tried mixing it and it falls apart, it's really obvious to the user, and you go, all right, not using it with that. But everything, almost everything that we used, it would be fine. So you could do that for small doses quite easily, and if larger doses are needed, then maybe if the thickness of the liquid isn't safe, then it might be more appropriate to go back into crushing tablets or looking at using powder thickeners, maybe with a larger volume of medical liquid. They can be useful, but only if you potentially have to thicken them.
So we've been talking about how we can administer tablets, pills, also with the gels or other formulations. But what about the medication? So are there kinds of medications that are most often associated with dysphagia, so that can actually lead to dysphagia as a side effect? And what are the mechanisms involved?
Right. Well, medications that affect swallowing function are mostly those that affect muscles or nerves involved with swallowing, all things that cause dry mouth. And unfortunately, there's so many, where do you start? If we're worrying about it, we would flag anything that acts centrally. And so they interfere with muscle control and coordination. So it's things like blood pressure medicines, pain medicines, medicines for anxiety, depression, anticonvulsants, antipsychotics. And then we would start looking at things that might irritate the esophagus and cause reflux. So that would be things like non-steroidals, calcium channel blockers, bisphosphonates, some antibiotics, some supplements, actually. And so it's a bit of a minefield. Actually, we start with treating one condition, and then the treatment causes a side effect, and then we've got to try and find another medicine to combat that side effect. And yeah, medicines can be quite complicated, and they can have side effects. Normally, though, you don't tend to find that somebody goes from zero, no dysphagia, to suddenly dysphagic from a medicine. Yeah, it's just that they enhance the problem. They make it more difficult to swallow when you're already on that trajectory.
Yeah, that makes sense. And I think, like you said, especially dry mouth is really an issue. So you said that you might be able to add another medication to kind of resolve this issue. Is this always possible? And actually, does it make any sense? Or what are your options here if you find, okay, it's making dysphagia or dry mouth worse? What are the options?
Oh, look, if you find somebody who's on all sorts of medicines and you think that their dysphagia is getting worse and you think it might be something to do with the medicines, immediately they should be looking at having a medication management review. And that's something that pharmacists are really keen to do. Just have a really good look at everything they're taking and look at whether there's alternatives. They'll be looking for anticholinergic burden. And it's not straightforward. Everything's on a case-by-case basis. You're going to look at whether the tablets that are being taken can be cut and crushed, or whether you can slot in something else that will help, whether you can pull out some medicines, perhaps they aren't all needed. Certainly towards the end of life, as you get older, there's some medicines that really they're there to help your cholesterol, but perhaps you don't necessarily need those, and perhaps they're contributing. So it's really important to do a thorough medication management review.
Looking at the future and future developments, or maybe also current research that might influence the future, are there any new developments or innovations in pharmaceutical care that you are excited about that are aimed to improve the medication administration for people with dysphagia?
Oh, wouldn't it be wonderful to be able to say, oh, yes, with this new thing that's coming along? But unfortunately, I don't see it on the horizon anytime soon. For now, realistically, there's a step forward from using food into using swallowing gels, because they're at least designed with with particular properties in mind. They've been made specifically for this purpose. And as pharmacists, we really like the sort of pharmaceutical nature of them. They're very, very reproducible. When you pump or squeeze that onto a spoon, how it's going to behave, and it's high quality, and it doesn't need to be stored in the fridge, and it will always do the same thing. So we like that, and that's pretty much as far as we've got. And so alternatives to crushing tablets would be the ideal. What else can we do other than mess up with the dose form that's been beautifully designed as this tablet? No, we're just going to go and crush the hell out of it. It would be great to think that we could individualize medicine. So for each person, one person likes having a disintegrating tablet. Well, maybe, they should have all of their tablets as disintegrating tablets in their mouth. Or maybe they like the idea of having medicated films. Or maybe actually, there's some other form. Perhaps they want a liquid. It would be nice to think that everybody could have those options. But a large scale commercial level, I think we're yet to see much impetus from the pharmaceutical companies to really consider swallowability. And understandably, there's cost implications of it as well. In the more distant future, blue sky stuff, I think we'll see more from 3D printing, because we're looking at individualizing dose forms, and you can combine multiple medicines into very small spaces. So I think that's, and so you can individualize a medicine. You can imagine a pharmacy having a 3D printer. They can program in what they want, and out comes this batch of tablets that's got 5 different things in it at the right dose. That's not the 25 milligrams or the 50 milligrams that you can get off the shelf, but perhaps they need 37 milligrams. And you could imagine making a beautiful little dosage form that might then dissolve in the mouth. I think that kind of thing might be. It's probably a long way off, but that kind of thing would be good. But then I also think there'll be things that avoid the mouth completely. And there's some work with microneedles. So you can imagine patches for transdermal, but they actually really enhance the penetration of medicines from transdermal patches. And perhaps we'll see more medicines move that direction ultimately. But I think that's a long way off, unfortunately.
Yeah, but it still sounds exciting, especially the 3D printing part. I think we can use it, as we had in our last episode, for actually printing food in different consistency at ITSE levels. So, and yeah, you seem to be really excited about that. So, yeah, we look forward to that.
Yeah, I think there's a lot of opportunity. We need people to pick it up and run with it and see what they can do.
So do you have a take-home message or take-to-work message for speech and language therapists working with people with dysphagia? What should they pay attention to? And I remember from my master's lecture, for example, the title was Don't Rush to Crush. Would that be an advice you would give to people?
Yes, so don't rush to crush is a really good idea. Don't just get in there and crush everything without thinking about it. But it doesn't mean don't crush. I think crushing is okay in the right circumstances, and sometimes you have to.
And is there anything else that you would like to recommend?
There's so many things that are involved in deciding what vehicle to use, that there needs to be a kind of a priority list in that decision process. And so this is my priority list. The first most important priority is safe swallowing. And so whatever the vehicle is that you select, it just has to be the most appropriate thickness. That's the most important thing, because obviously an unsafe swallow has got the potential to be deadly. So that has to be the priority. Then second in line is making sure that the entire dose of the medicine is swallowed, because we see time and again that the crush and the transfer of powder step can way too easily leave a large portion of crushed powder on the bench, in the mortar, in the medicine cup, but not being swallowed. Then third in my list is selecting a vehicle that's got the right flavour and texture that the patient likes, so that they don't avoid taking the medication entirely, or so that the process of taking their medicine doesn't contribute negatively to their quality of life. It needs to be something that they're enjoying. And then down in fourth place is trying to avoid a vehicle that's specifically contraindicated for a specific medication, or at least use a minimal quantity of it. So that examples of that are obviously yogurt for tetracycline and quinolone antibiotics, or fruit juices for statins, cyclosporin, or nifedipine. They're commonly avoided in those situations. But I put this one last in my list because, quite frankly, if yogurt or thickened fruit juice is the only thing the patient likes, then it is way more important that they swallow the medicine at all than worrying about a slight delay in absorption or a reduction in the effect of the medication. And realistically, it's most likely to cause a therapeutic issue if it's a different method that's being used each time. So if you can use the same yogurt or the same thickened fruit juice consistently, then if there is an impact on the therapeutic effect, then the medication dose can be adjusted to get the therapeutic effect that's needed. So, obviously the ideal scenario is to use a medication swallowing gel that's the right thickness, because they're actually designed specifically for the purpose of getting a medication from the mouth to the stomach. And from all the work I've done with them, they really are compatible with pretty much any medication. They don't need to be stored in the fridge. There's a nice range of flavours that are going to suit most people. And most importantly, there are swallowing gels you can get that are available in IDSI 3 and 4, even IDSI level 2. So to suit the needs of each individual dysphagia, you can pick something from those ranges. Ultimately, just aim to figure out what is safe for the individual and keep using that same safe approach consistently for every dose.
Great. Thank you so much, Kathryn, for taking the time and sharing your knowledge and insights with us today. Thank you.
Thank you so much.
Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.